Thank you. So I think everyone had enough with me, but let's finish the day with a big fun talk. So just to shift gears and talking about more like, say, surgical cases and post-surgical, let's see what the surgeon have done and how can we fix it. So moderate to severe MR has been have high incidence in elderly population, and it has associated with morbidity and mortality, and we know that. And the options percutaneously to save these patients is a bit limited, and they usually go with the direct replacement. So let's talk about some surgical failed bioprosthetic valve, either in the mitral or tricuspid, because we know the lifespan or the life expectancy of these valves range between 10 to 15 years if you're lucky. And TEER may be not an option in these cases. So I'm going to just make it very simple, couple of cases. It's a very prevalent, as we know, here in our region, but alhamdulillah is now getting down, rheumatic heart disease. So we have a patient who had a mitral valve replacement using Magna 29 in 2010, and then presented in 2019 with class 2 to 3 shortness of breath and symptoms. Her echo is showing that there is a severe degeneration with a severe mitral valve prosthetic stenosis with a main gradient almost reaching 13 at the heart rate of 70. She wasn't in atrial fibrillation, just to mention. The PA pressure was in the good thing. The right side was doing fine, and the aortic was fine. So it was discussed in the combined meeting, and it was decided to go for percutaneous option in favor that they don't do a redo first the surgery. So these are intraoperative images after achieving a transeptal puncture, usually in contrast to the mitral clip where you have to have some height and you go more posterior. You don't need to be that high in the valve-in-valve situation, because if you are very high, you will have difficulty maneuvering the system. So usually we go with the same standard SL1 catheter, BRK needle, or if you're lucky, you have a radiofrequency to have a more precise transeptal puncture, which I would suggest because usually these are surgical septums. So push through them with a mechanical transeptal puncture may be a bit of a challenge. So if you have a Baylis or a radiofrequency, go with it. Agilis, which is a flexion catheter, which is basically used more in the electrophysiological arm. You can use them. It can help you with that to direct you and go through the valve. So as you can see, we're going through the valve. And after we cross the valve, we put a confida wire across the valve, and we balloon the septum, because now you're getting into a surgical septum with a 14 French, tough, stiff. It's not like the mitral clip where you have a flexion extension and plus and minus, where you can wiggle yourself through it, or you have a dilator. You don't have this option in the Sapien, so that's why you need to balloon. If you're using, in our case, like a 29, this is based on, you have the application, and you can see the inner diameter and outer diameter of the valve to make the best choice. It was more compatible with a 29, so you just have to pre-dilate the septum with a 14 or 16 balloon. After that, you position, of course, the mounting of the valve is a bit different. It's not the aortic. You just flip it upside down, and you just start to replace and adjust. As you can see, the operator here, one is fixing the balloon, inflating the balloon, and one fixing the wire, and while the primary one is positioning the balloon. So it's a team and harmony. So you have to have a harmony between your team. And you can see like a good scanning going through the valve, and you can see well-opposed valve. And this is after the deployment. And next day, the gradient is 5 with a small intraatrial shunt simple, and she was discharged. So it isn't that easy. We make it looks like a very fairy tale, but it actually is not that easy. It's more difficult because, first of all, this valve that we're using, the Sapien, is not designed for mitral. It was designed for aortic. So we're kind of bending the rules already. And we don't have always a valve that can hold my valve. Maybe you can have a ring or you can have a MAC. And as we go forward with MAC, the results on mortalities and morbidity with 30 days and 1 year wasn't very favorable. So it's not an easy situation. And if you have a surgical valve, which is rigid and small, you can expect some gradient. And we know that gradient is not good, and it's associated with independent predicted of morbidity stuff. What about the other challenges or open issues in them? We're talking about what the possibility of paravalvular leak, having an LVOT obstruction, access misuse, or possible if you have it in a non-rigid annulus or a band, you might have a problem with embolization. And then the question of antiplatelet or anticoagulation post-procedure, what is the best course? Is it going to be a NOAC? Is it going to be warfarin? Is it going to be aspirin and Plavix? Still, the jury is out. So we have still questions going on. I don't see much of a future in terms of the valve-in-valve in this. I think we will be pushed to do it as a salvage procedure. Maybe when we have a more definite valve replacement, or we find a more microscopic or simple surgical approach to decrease the surgical risk of a redo, then you can have something more durable. What about the tricuspid? Now, this case is tricky. He's a 33-year man, simple situation, rheumatic heart disease. His procedure happened like 7 years ago. He had a mitral valvotomy in 2002 when he was like very young in his teens. And then in 2015, his ejection, he came with fulminant heart failure, anosarca and everything, severe mitral regurgitation, severe tricuspid regurgitation, severe aortic regurg. It's kind of the nightmare for the surgeon. And the surgeon took him despite everything, and he replaced the 3 valves, 2 mechanicals, mitral, aortic, and put a tissue in the tricuspid. The course of the patient didn't finish this way. He arrested. He had a very stormy course afterward requiring ICD. The ICD didn't work. He had to put another ICD. So once you see the chest X-ray, you will understand what I'm talking about. Luckily, the patient did very well. His ejection fraction recovered. Everything is good. Then 7 years later, the valve started to degenerate, his tricuspid mainly, with the severe stenosis with a gradient of 16. Like we were talking, how is it compatible even with his life? And you can see out of the back how much of a hardware is in him. You can see this is initially during hospital course, this is what was putting in him in epicardial leads. That's why you find lots of hardware. Then by the dysfunction going on with this, and they put another one for him, I think 6 to 8 weeks later on. And you can see it was very tailored, and they went outside the valve. So these went through the coronary sinus and, some fancy veins that the electrophysiologist used just to avoid going through the valve at that time. And you can see it's very hard to see even this valve. So we have discussed this case, and the strategy was like, the surgeons had a flashback of, 2015, and he said, okay, wait a minute, let's make a plan. He's 33 years old. If we took him to redo, he's going to degenerate again by the age of 40, and we have to open him again. And then he will degenerate again, and we have to open him again before he's 50. So why don't you just go for a valve-in-valve now, give him maybe 8 years, 10 years, and then we redo him, and then you put a valve-in-valve or something, percutaneous option, hopefully, and then we redo him again. So that was the thinking for 20 years. And the patient asked me, what after that? I told him, I'm going to be retired, so I don't know. You have to deal with it. So anyways, so it's a St. Jude 31. It's a very good, these markers of a different valve, but just like to have the course of it, like Edwin has kindly mentioned that sometimes you can use the CT to have better understanding of the valve and the inner diameter. And you can have predict even if you can consider some RVOT obstruction or stuff like that. And then this is our valve. It's like a flimsy line, and then this is coming from the app. It can help you where exactly to land your valve, and you position it. So for those who cannot hardly see it, this is the band. Okay, you try to give it in one line. It's very hard to see. I don't know. It doesn't show it, but it's exactly under the mitral valve. And then what we did in the right side of the page, we went with the extra stiff and Platts wire. We extended it until to pulmonary because we want to have a railing support to push the system across it. Okay, so that's why you'll find the wire extending up to the pulmonary. After that, as you're pushing, now you're using the wire as a guidance and a support, and now you can see exactly where is the thin line. It's very hard to see from here, but I hope you can see it. Once you see the dot stop, you know that we are there. And on the right side, we started to inflate. Let me just play this. Yeah. So you can see here from the right side of the page, because we know it's going to shorten from above, like an opposite to the in the aortic. And we position it with a very calm situation because, again, the harmony in the team, one is holding the valve, one is controlling the wire to some extent, and the ballooning. Because once you lose this harmony, you will find the valve either in the RV or in the RA. And this is the final shot. You can see very thin line of the valve around it. So next day, this was happened in Ramadan, like in April, good gradient, at least from like 17 or 16 to 5 with no residual tricuspid regurgitation, and it was a successful case. So it's not that easy. It might look easy, but it's not that easy. So you have to plan your case. You have challenging open issues going with it. You have to pick what valve. Each valve have its positioning. You can see from the application. It depends on the kind of van. If it's St. Jude, if it's Magna, to position your valve. So familiar with it to have better understanding and positioning. This is another case. This is courtesy of Dr. Gilbert, a case he did where he used a different valve. You can see he used a 23 sapien valve, and you can see it's a smaller in size in the other patient of his, but he did like an extra length, and he did an RV angiogram to show that there is no regurgitation now or any paravalvular leak, which is like, a successful case. But you can see there is like, the waist. Some mentioning that it's more in the mitral. If you have like some gradient, you can crack the valve, but I have not done it, and I don't want to do it. So it's out there as like in your toolbox if you need to. So the same case, transthoracic post-procedural pre- and post-implant. You can see the jet is better now, no more TR, and an eventual recovery and home in 2 days. And this is the beauty usually of percutaneous approach. You can have the patient home within 24 hours from the procedure. And this is, again, an extra, like if you have a CT and you have, the program, it can help you to plan and have more details. And I think there's some published paper talking about using it in a 3D and print out and to understand where to land your valve exactly. So to take home message, transcatheter valve-in-valve procedure have been shown to be feasible and safe. They are safe and simple and capable of improving the quality of life. And hence quality of life we're talking yet. Accurate patient screening by multidisciplinary heart team taking into account the LV and the RV function, the pulmonary artery systolic pressure, and the comorbidity and frailty of the patient and the life expectancy is the outermost importance to optimize the results and the effectiveness of this valve-in-valve. Patient selection is always paramount, and the poorer the multimodality imaging with multimodality imaging with CT, transthoracic, TEE is crucial for deciding which procedure and which device is the most appropriate for the individual patient. And with that, I thank everyone.